يسعدني الآن أن أقدم المتحدث الثاني أستاذة الدكتورة نجوى رحيم، أستاذ الغدد الصماء والسكري مركز طرابلس، مركز سكر طرابلس ليبيا، رئيس الجمعية الليبية للسكري وعضو هيئة تدريس بجامعة طرابلس. تفضلي.
Assalamu alaikum wa rahmatullah. Thank you, Mr. Chairman, for the presentation. First, I want to thank the preparatory committee for the UEDA conference for inviting me to share with presentation in this conference. And special thanks for Professor Misbah Kamel. Today, I will talk to you about diabetes and Ramadan and risk factor stratification. This is the agenda of my presentation, but sure, the previous speakers, they talk a lot of points. I will try to stress on some of them and to summarize. We will concentrate in this presentation on the DAR risk factor calculator for 2026. قال الله تعالى في كتابه الكريم: بسم الله الرحمن الرحيم، يا أيها الذين آمنوا كتب عليكم الصيام كما كتب على الذين من قبلكم لعلكم تتقون. شهر رمضان كلنا نعرف أنه هو من الأشهر المقدسة لدى المسلمين ولما فيه من فضائل وعبادات وطاعات، وصيام شهر رمضان من أركان الإسلام الخمسة، وهو فرض على كل مسلم ومسلمة بالغ قادر صحيحا على الصيام. Muslims are almost approaching 2 billion persons all over the globe, and it's equal 25% of Earth population, and the number of Muslims is increasing. Likewise, diabetes type 2 prevalence is increasing. If you look here, the main bulk of the world Muslims is accumulated in the region of the Middle East and North Africa, which is our region, and also they equal around 20%, and also in Southeast Asia, around 61%. These three regions with high Muslim population are expected to see more than double of the number of patients with diabetes in the next 25 years. The diabetic population in Africa is projected to have the highest increase in prevalence of all the IDF regions, which is equal to 143% by the year 2045. The IDF MENA region currently has the highest age-adjusted diabetes prevalence of all the IDF regions. Multinational and regional studies in the past decade shows important information regarding the frequency and the characteristics of diabetic people fasting Ramadan. These data are better, give us a better understanding for the pattern of fasting in different geographical areas. As you know, this is the first study, which is the EBDR study conducted in 2001. Followed by the CREED study for 2010, then the DAR MENA Type 2 Diabetes 2016, and followed by the DAR Global Survey 2020. From all these data, the risk factors or the major risk associated with fasting in patients with diabetes include hyperglycemia, hypoglycemia, DKA, and dehydration and thrombosis. For sure, a lot of points mentioned before, but just I want to stress on hypoglycemia risk. It is less frequent in type 1 and more common in type 2. But it is more associated with higher mortality in type 1 diabetes. DKA risk occur especially in those who are poorly controlled before Ramadan, and the risk may be also as increased because of excessive reduction in the treatment dose or insulin dose based on the assumption that food intake is reduced during the month. Again, I want to stress on type 1 diabetes that more adults with type 1 diabetes are being able to fast for at least 15 days during the month in recent years or data. And there's one of type 1 diabetic, 1 in every 4 is able to fast the whole month. This is according to DAR Global 2020. Maybe because type 1, they are usually using the SMBG or self-monitoring more frequent, especially those who are younger than 18 years of age. In type 2 elderly people, they have a higher rates of break fast. Why? Because maybe this is explained by the longer duration of their diabetes and the use of insulin, higher rates, and also because of the presence of comorbidities and diabetes-related complications. Elderly people, they have a higher rates of hypoglycemia and hyperglycemia, and also they have a higher rates of requiring acute hospital admission, whether emergency or hospital admission. The IDF and the DAR International Alliance, they deliver a comprehensive guidance on diabetes and safe fasting, provides healthcare professionals with information, help them to deliver the best patient care, and support minimizing the complication risk. Risk stratification is essential for guiding individuals with diabetes during Ramadan. So, after the recent multinational surveys and the real-world data, the 2021 IDF DAR risk calculator established. And it provided a structured and evidence-based approach and the new insights in patient characteristic and therapy patterns and disease complication. We'll talk about the IDF DAR risk calculator 2026, and this is the link if somebody wants to use it. We make a copy. The IDF DAR risk calculator developed through a multi-stage consensus-deriving process. It revised the latest literature and case scenarios and incorporated the data from the DAR Global Survey and other regional validation studies. Risk factors including frailty and pregnancy and multiple microvascular complication and therapy-related elements. They were systematically re-evaluated to enhance the predictive accuracy and the clinical prevalence. A key modification in the 2026 risk score calculator is that it includes a refined hypoglycemia threshold, also the incorporation of advanced diabetes technologies, and the reweighing of the patient vulnerability factors. The updated calculator stratifies patients into 3 groups, low and moderate and high risk group. So it is around 14 risk factors has been analyzed, and we will take a few points from here. First, pregnancy. Any pregnant lady with diabetes is considered a high risk, and she is scoring very high, 6.5 points. Also, patient with hypoglycemia. Unawareness, they score very high, 6.5%. And also, if you look for the macrovascular complication, those with unstable macrovascular disease, they are scored very high risk, 6.5. And those with microvascular complication, especially those with nephropathy, with the estimated GFR less than 30 ml per minute, they are scored high-risk patients. And in the presence of microvascular complication like neuropathy, foot complication, diabetic retinopathy, if the microvascular complication, they are combined, the score will be higher. For example, if the patient had 3 microvascular risk factors, he's scored 3. If 2 microvascular complications, he scored 2, and if 1, he scored 1, if none, he scored 0. Also, cognitive function, very important for elderly population, and fragility, type 2 for sure, and the age. They are scored 6.5, which is a high score point, those with impaired cognitive function and advanced friability. The new thing in this score that people who are using the CGM and it make fasting more safe, they are scored by negative score, which is minus 0.5. So risk score and risk categories are categorized into low risk, those who are scored 0 to 3. Those who scored 3.5 to 6 are considered moderate risk, and those who scored 6 or higher than 6 scored high risk. طبعا ما فيش 3 and الend here 3 and here 3.5 ما فيش في الوسط any figures لأن scoring it doesn't include 3.15 or 25. The DAR 2026 risk score aligns the medical guidance with religious consideration, and it strengthens shared decision making between patients and the clinician and the religious authorities. So if you look here, those who scored low risk, fasting is probably safe. Where religious decision depend on the severity. يعني لما يكون في risk على البيشنت أو خطورة, he should avoid fasting. And fasting should be يعني inhibited. فالlow risk they are able to fast. Fasting is obligatory for them, and the advice not to fast is not permitted. For those who score high risk, more than 6, fasting is unsafe. And in this group, they are advised against fasting. A moderate risk score between 3.5 and 6. Fasting safety is uncertain here, and things should be discussed with the patient, and the medical evaluation should be done, medication adjustment should be done, and strict monitoring should be advised to the patient if he chooses to fast. So for moderate risk level, the moderate risk level are advised to fast. يعني هي في الأول كان في الجايدلاينز الأولى advised not to fast, but last أو new guidelines the patient choice is permitted, and if they choose to fast, we should give them a structured education to be aware when to break fasting and the time to stop fast if the clinical condition deteriorate. The most important in risk scoring should be repeated annually. يعني مش نفس الريسك سكور يتعاود كل سنة لأن patient condition and situation changed. The advantage of calculation of the risk score, it supports doctor in making decision, and it is motivating the patients and having a good outcome and relating both medical and religious fasting aspect. So, optimizing strategies for the management of diabetes during Ramadan. I want to say here that more evidences support the use of pre-Ramadan education for safe fasting. It helps patients to know the risk and to recognize the time to break fast. We need more pre-Ramadan focused diabetes education targeting diabetic patients and healthcare professionals, and also we need educational campaigns to targeting general population, and telehealth technology is in use. So to summarize, fasting Ramadan carries a risk for some patients. Type 1 diabetes are high risk group. Type 2 have a less risk, but diabetes duration and fragility and age and comorbidities should be considered. Pre-Ramadan risk stratification remains essential, and the DAR 2026 risk calculator updates offer a refined and evidence-based frame network for evaluating fasting risk associated with diabetes by integrating emerging real-world data and updated therapy consideration and individual vulnerability. Many patients will insist on fasting, so we should work on them and through education to know when to break their fast if needed, and the use of stress on using the SMVG and medication adjustment, and all these should be applied to avoid hypoglycemia. And thank you.
شكرا دكتورة نجوى. يسعدني الآن أن أقدم المتحدث الأخير في هذه السيشن، الأستاذ هاني الجيلاني، جامعة سوهاج.